So good morning, everyone, and welcome to CAHN's Health Hour. This has been running since the beginning of May, and we're really delighted for all the support and grateful for the support that we've received, from our health professionals who give their time on Saturday mornings, considering a number of them do work, incredibly hard in the course of the week. We're really grateful. So this morning we're delighted to have Dr. Maame Sarfo, no, Dr. Maame Sarfo, with us. Apologies for the mix-up there. Who will be taking us through perinatal, psychiatry. Dr. Sarfo, has been with us for a while now, and she's been given, time and talking about various subjects in relation to mental health. As many of you are aware, she's a consultant psychologist, and she will be talking about, perinatal mental health. So over to you, Dr. Sarfo.
Thank you, Mr. Charles. And once again, thank you for the opportunity to speak about mental health. And my aim is to try and, along the lines, destigmatize it as much as possible. Today, we are hoping to kind of broadly talk about perinatal psychiatry. It's quite a broad topic, but so it will be a lot of generalization. But then, as Mr. Charles said, along the line, if you have any specific questions, please feel free to interject or ask as we go along the line. I would like to correct, I'm a consultant psychiatrist, which is different from a consultant psychologist. So, yes. So if we start, my aim this morning is to really kind of make it why perinatal psychiatry is quite pertinent, and it's quite something that has to be on top of most of our minds, because we're all in a society where we meet a lot of pregnant women. Most of us do. The women on the group would get pregnant at points in times in our lives, and the men, we have wives or sisters or siblings, children who would get pregnant. So it's quite a relevant topic. So hopefully make it as relevant as possible. As I said, it's quite a broad topic, and perinatal psychiatry just means that we are looking at pregnant women and women who have children up to the age of 9 months per se. But then any woman can have all the range of mental illnesses, but there are some mental illnesses which are quite common when people are pregnant and during the first 9 months. So those would be the ones that hopefully we'll be mentioning and focusing on. But that does not mean you can't have any of the other numerous mental illnesses that we might not mention. I would also hopefully touch on the management, where we talk about psychological management in terms of, if you put it generally, a talking therapy, and also what we call social management, which is what as a society or as families we can do to support women who are pregnant or women who have children up to age of 9 to 12 months. And also then at the end, hopefully look at medication, not to discuss specific medications per se, but to mention the controversy or the concerns, understandably, about medication and where it fits into all this, really. So to start with, there is, I'm assuming most of you would have heard of a condition called bipolar affective disorder, which is generally thought to be one of the very serious mental illnesses. And that is one of the very conditions that during pregnancy and after birth, most women who have that diagnosis previously can't or tend to suffer quite significant number of relapses during that period. So we can get about 50% of women who've suffered with bipolar or have that diagnosis already, tending to have relapses during the pregnancy period. So it's quite important that anybody who has had that diagnosis in the past keeps it in mind, or if you know of a relative who has a diagnosis in mind. Most of the time, actually, at present, the government has actually pumped a lot of money into perinatal psychiatry. So you tend to get letters from GPs or psychiatrists or mental health services prompting you to make contact with them because of the seriousness or the possibility of relapses during that time. I'll go into the specifics of what some of the examples of what I mean by bipolar and what the symptoms might be. Depression is also quite a very important condition during mental health period, during pregnancy and after birth, because up to, if you've suffered with depression, when you take a population of 100, 68% of people who have suffered with serious, most of the time serious to severe, moderate to severe depression would have a relapse during the pregnancy period or during the after birth. So it's quite one of the very important diagnoses that we are, a lot of attention is put into. Also, anxiety disorders are also quite common. You have about 20% of people getting anxiety disorders. And I think why pare-natal psychiatry, understandably, is being, well, if you can say hyped up or is being talked about a lot, is that it's well documented that 50% of pregnancies are generally unplanned. So therefore, one has to, even without necessarily, so most pregnancies are unplanned. So if you have any condition or if you are on any medication, there is always that discussion, especially between women with in the childbearing age, to be always conscious about any medication, be it mental health or be it physical health, because if you take 50% of pregnancies are unplanned, then you have to think about the potential that any medication at all would have on a fetus, a pregnancy, or subsequently the child. So that is why it's always very important, just not perinatal psychiatry, but any medication at all, that we always be thinking of the impacts on any pregnancy. And mental health generally has an impact on the fetus during the whole pregnancy itself, on the child, the whole family and society as a whole. And it's quite important when somebody has a woman suffers a mental illness, the impact is just not on her well-being, but you have the fetus being an issue, having an impact on the fetus as well, and also the children, other children that are in the family and the whole family in general. So that's just looking at some statistics and why it's important to keep prenatal psychiatry in mind. So just going into some common presentations. So one of the commonest mental illnesses or mental health issues that come up is what we call, hopefully most people have heard about it, is perinatal blues or baby blues. And it's a very common condition, and it's felt that actually about 60 to 80% of women who during their pregnancy and after birth, it is mostly after birth, in the first 2 weeks do suffer some symptoms that are similar to depression, but then the length of time is just for over two weeks. So it would just last for over 2 weeks, and therefore it doesn't really go into depression. So most women would, during the first days after giving birth, might kind of feel sad. There is that general feeling of being incompetent in what you are doing, or not being able to, especially with first-time babies or first mothers, that you have that sense that you're not sure of what you are doing. And it's a very common sense. People, women tend to feel sad, not confident about looking after the baby, but generally they tend to eat well and manage to sleep reasonably well within the context in which we are talking. And with most we call it postnatal blues, and with most of such situations, it's felt that after 2 weeks it settles down, and most women then tend to get their confidence back and also tend to be then more able to look after the baby, and the sadness reduces over time. So that is what we call postnatal blues, and it's very common. So most people shouldn't necessarily be worried about it, and most midwives and health visitors are well trained in that, so they'll pick it up, and most of the time all you need is reassurance to build your confidence back. Sometimes, unfortunately, if it persists after 2 weeks, which about 20% of people with women, after 2 weeks, it would, if those symptoms of sadness, not having any motivation, the feeling of being incompetent, not sleeping well. We don't necessarily, if outside pregnancy or outside the first 9 months, we would take it into consideration when we are thinking of depression. But because it's a very common issue during the first, when you have a baby around, it's not generally a symptom that we look for when we are thinking of depression. So when we're kind of thinking of depression, we're looking at difficulties looking after baby, overly anxious about things, always feeling that there's something wrong with the baby, feeling hopeless, withdrawing. Those are symptoms that we're starting to look at. Okay, is this person, and it's after 2 weeks, looking at, is this person getting depressed, or is this person depressed already? And that is where hopefully a midwife will be a health visitor, most likely at that time, because after 2 weeks after the birth and along the line would pick it up, or your GP hopefully should pick it up and refer you to the necessary services, really, depending on what it's rated. If it's felt to be mild to moderate depression, then hopefully the plan would be talking therapy. And I know particularly in my area, which is the Southwest, we have the improving access to psychiatric therapies, what we call IAPs for short, and it exists everywhere throughout the country, but they have different names. Do have practitioners who offer specific therapy for women in the perinatal phase, so women who are pregnant and women up to, some areas up to 12 months, some areas 9 months. There is specialist talking therapy available for them. So if your depressive symptoms are thought to be mild to moderate, then you'll be looking at most likely talking therapy. Sometimes medication becomes necessary and important, and that might be recommended, but then it's always in discussion with you. I'll go more into the details about medication at the end, because the medication is always tricky when you are pregnant, and also especially after the birth of it. So depending on what you are diagnosed with, then if it's felt to be severe to moderate to severe depression that you're suffering with, then, and depending on which area you're in, you might be referred to specialist perinatal services. And as I said, the government is currently pumping a lot of money into perinatal services. So most areas are obliged, apart from the general mental health services, they do have perinatal services, which see specifically to women who are pregnant. I think the pregnancy from 3 months up to birth, and then from birth up to 9 to 12 months, depending on the area. So all these services are available, and you would be referred on to the secondary services if necessary. So that's when we're talking about postnatal depression. And also, as I said from the beginning, sometimes because of the concerns about medication, the impact on babies, some women who are suffering with depression might choose to come off medication, and there is that potential that you might relapse, and we have issues with that. So I said 1 in 10 women would kind of suffer with postnatal depression, and it's usually between after 2 weeks of giving birth to 1 year. Perinatal, it can also happen in the course of the pregnancy anyway. Can start, yeah, as I said, can start in pregnancy, and 80% of people may not have had any mental health issues prior to becoming pregnant or giving birth. And as I said, what we call the biological symptoms in terms of eating and sleeping might not necessarily be reliable because of the context of it. Any particular questions before kind of I go on in terms of depression? And
I think, Maame, after you've done the presentation, then we'll get into.
Okay. All right. Okay. So then the next thing, kind of I wanted to talk about, it is quite a very serious, in any context, it's a very serious mental illness, what we call puerperal psychosis. Some people would call it postnatal psychosis. It is one of the most serious mental illnesses, because fortunately it is relatively rare, but most of the time the outcomes make it quite serious, because the outcomes do not have implications on just the woman, but on the pregnancy or on the baby as well. So kind of a common, just to give a scenario, we have a 21-year-old woman who's had a baby for 3 weeks. She found out she was pregnant 5.5 months into the pregnancy, and she was built up to labor, and then she has the baby now, but presenting as very angry at the labor ward, or when she's seen by relatives and professionals. She continues to express concerns about her labor during at the labor ward, which sometimes it is quite a relevant thing, but I think with this particular case, how she was expressing it seemed to be out of context. She was suggesting the midwives were not good at their jobs, and then she was making statements about having won the lottery and she was going to repair the services or pay them to fix the services. This particular individual was presenting with very poor sleep. And then when she had visitors, she would just be talking all the way through, very talkative compared to her usual self. She couldn't really interject in any of the things that she was talking about. She presented as very suspicious. And then she was calling her colleagues for work to give testimonial to her behavior and character. So it was all, this particular case was all out of keeping with her usual presentation. And eventually I think her health visitor saw her, and then GP, and then she was referred to mental health services. And we eventually diagnosed her with what we call a manic episode in puerperal psychosis. So that is one common presentation where people tend to present as overactive from their usual self, and they're kind of what we call manic in terms of saying things that are not really in keeping, being what we call grandiose, in the sense that maybe saying they are related to the prince or the queen and having won this lottery in this particular case. And it came across she was indeed very unwell, and she just kind of had her baby, and that's what we call puerperal psychosis. But this is actually one of the less concerning presentations. When we go to another presentation, I had this 35-year-old woman, and she had her bipolar. She had a diagnosis of bipolar 10 years ago. She had what we call a manic episode, in terms of she presented as very hyperactive. The things that she was saying was not in keeping with the context of her environment. And then eventually she settled then that was 10 years ago. But then right after this pregnancy, restless 5 hours after labor, not looking after baby, appears perplexed, like somebody looking very confused just right after having the baby. She wasn't really talking much, and then the labor ward, they found that she was just entering other people's room and then stating that she was looking for her husband. And her thoughts, you couldn't really understand what she was saying. She was saying quite a few things, but it all felt very bizarre. She was noticed to be mumbling to herself. And then her baby starts crying, and she just had the baby 5 hours ago, but her baby starts crying, and she doesn't seem to recognize that it's her baby, and calling other people to come and see whose baby is it. And then I think nighttime she was found wandering around. And she was kept asking for the baby's mother to come and pick the baby. Subsequently, she was diagnosed with what we call puerperal psychosis. But in her case, the other thing was also because she couldn't recognize the baby was hers, she felt that somebody had left a baby and she needed to take the baby somewhere. And there was concern about her care of the baby, with other episodes, which has made it quite pertinent and make puerperal psychosis. Women then tend to think the baby is an organism, or the baby is something else rather than a baby, and have thoughts of killing the baby, or not killing the baby just because they want to kill the baby, but sometimes they have thoughts that because the baby is crying, the baby must be in so much pain. Then we have women drowning their babies because of such thoughts. And you have women who then feel very incompetent in looking after the baby, or suffer very bizarre thoughts, psychotic illnesses, and go leave, I'm sure we've heard stories about it, leave the maternity ward and just go and jump over a bridge. And that is where it makes puerperal psychosis a very concerning illness. And I think what also makes it very concerning is how rapidly it changes. This woman just had the baby 5 hours, and she was fine before that. There wasn't any concerns, and you can see how rapidly it happens. Most other people, within a matter of days, you start to see some odd behaviors, and within a matter of days, they've gone into full-blown psychosis. Fortunately, I think the awareness, hopefully, is there within professionals, not just mental health services, but GPs and A&E services. And most of the time, we try and give prompt attentions to such diagnosis. So just to give some statistics to it, as I said, it's quite with most people, it's sudden onset. It just we have people saying, "Oh, I just saw her yesterday and she was fine." It just happens so rapidly that it can be kind of an interesting one to see. The urgency, we treat it with utmost urgency, because when women are pregnant, you have some women who are starving their own selves because they think there's an organism in them, or women who might end up killing their baby because they think they're doing the baby a favor by stopping the baby crying. So it can be quite a difficult one. Fortunately, as I say, it's not that common. It's not that common. I think the main issue, the main concern is how the seriousness of it, and that's why we try to speak about it. 1 in 5 women who have a formal diagnosis of bipolar affective disorder would suffer puerperal psychosis. There is also, it tends to happen most of the time within a week to 6 weeks of giving birth. That is where the commonest presentations happen. But having said that, it can happen anytime after that as well. But most common presentations are within the first week to 6 weeks. People, unfortunately, women who have suffered it before in previous pregnancies, there is always a 50 to 90% chance that would happen again in subsequent pregnancies. And that is where most areas, you find that the services will be writing to such women to start not waiting for the symptoms to come up, but start giving them the reviews and attention as necessary. If it's happened if your mom had it before, or your auntie, if it has happened in your family before, somebody within your family has been diagnosed with this before, there is, depending on how close you are to in terms of the network, you might, in terms of hereditary, I mean, there is a chance that one might have it as well. So family history is also quite relevant when you're thinking of puerperal psychosis. Okay, so that puerperal psychosis is kind of the commonest ones. We have issues there is also concerns about personality disorders per se, and we have the various personality disorders. But then I think the commonest personality disorder that tends to come to attention of services is what we call borderline personality disorders. And it can go two ways with borderline personality disorders. By virtue of the diagnosis of how people present, some people do well in pregnancy because they have the realization there is somebody else to take care of. So you have people who have the diagnosis of personality disorder who tend to function well when they have a baby. With some people, unfortunately, because of the experience they've had, which has defined them to have that diagnosis of borderline personality disorder, some getting pregnant or having a newborn child, unfortunately, triggers those memories and the anxieties of maybe if somebody has been abused as a child before, then the anxieties of not being able to protect their child enough to suffer that abuse might happen. And that is kind of where the personalities can unravel. But there are services available. Most midwives are being trained well in mental health service, in common mental health issues, especially the ones that are common in perinatal period as well, to pick them up and refer them on as necessary. So you might just be referred on to the IAP services within GP or what we call primary health service, or you might be referred on to secondary services, which most places, as I've said, have perinatal psychiatric services available. Anxiety disorders are also quite common, and the anxiety disorders is quite a broad one. We have the commonest ones that tend to come up is what is commonly known as OCD, obsessive compulsive disorder, and that is because of the challenges of looking after baby. And then when you have obsessions about counting and about things being very neatly placed, then you can imagine when you have a baby and you don't necessarily have control over the situation, you can see how such individuals who have that diagnosis can unravel. But then once again, there is hopefully a midwife or a GP can pick it up, and then the prompt attention will be given to it. We also what we have some people might not, some individual women might not necessarily have any mental health issues before in the past, but sometimes unfortunately the labor can be so traumatic that they tend to, some people then subsequently suffer with PTSD as a result of the trauma that they went through during that time. Most obstetric services, most gynecology and obstetric services have the awareness of it. And I am aware that my area in particular, I'm aware that they do then offer such women subsequent psychological input. So somebody to talk to, a proper psychologist to talk to help identify such issues, if indeed that is what's happened. So the services are available. I think you just need to speak to your GP and speak to the midwife, then those things can be prompted. So kind of looking at, so those are, once again, I have to emphasize what I've mentioned are the commonest that happens during pregnancy. But having said that, any mental illness can happen during pregnancy. One particular one that I didn't have an example of in terms of a scenario is also people who've been, individuals who've been diagnosed with schizophrenic illness, or what we call schizophrenia, can have relapses during pregnancy. Fortunately, it's not as common. Their relapses is not as common as where you have people who have had bipolar, who have a diagnosis of bipolar affective disorder. But if you have people who have a general diagnosis of schizophrenia, can suffer with puerperal psychosis as well. But once again, such people with serious mental illnesses should have letters from their GPs or secondary services as soon as the pregnancy is identified, so that the necessary services are put in place. Because of the seriousness, like when we talk about bipolar affective disorder, schizophrenia, and indeed moderate to severe depression, because of sometimes the potential of serious outcomes of it, we have most areas, most perinatal services have what we call pre-counseling services. And what these pre-counseling services tend to do is that when you identify to have a serious mental illness, then you see either a nurse or a psychiatrist to have a discussion about the potential implications of having a baby. And most of the time, it's important for one to reach out to services when you're thinking of having a baby and you have these established diagnoses already. And it's just really, they call it pre-counseling, preconception counseling. And the idea is to help you think through what the challenges are going to be in terms of the potential of how you having a relapse whether it's it will be important, whether it's important for you to stay on the medication or you'd want to come off medication, the implications of coming off medication, you would have to, they help you think that through. Which services, who needs to be aware of your diagnosis, and which services that yourself or your relatives can assess when you do become unwell. So that is where the preconception counseling comes in, and it's quite important. I think there's maybe the opportunity to speak a bit about the challenges of medication. Rightly, with any pregnancy, most women worry about any medication that they are on and the implications on their baby, the impact on their baby, because sometimes with some medications, it's just not the impact on the fetus where you risk maybe getting aborted or malformations. There are some medications, specifically what we call sodium valproate, which we try not to use it, as we use it if necessary or as a last resort now in women of childbearing age. Sodium valproate, it has different names. Some places where they call it valproic acid, some places they call Depakote. That particular medication is known to have an impact even when children are born. So it has an impact on their cognition. So that is actually well recognized now. So unless there isn't any other medication, most women in childbearing age, you would not be prescribed sodium valproate. That was just to give it as an example. So all medications do have an impact, even paracetamol. And the issue with medications is that it's deemed, or rightly so, not to be ethical to try any new medications on pregnant women. You cannot, under any circumstance, try a new medication on a pregnant woman, because you're not just dealing with one individual, you're dealing with two individuals. So ethically, you cannot do that. So with all medications that are recommended or advised to use during pregnancy, be it mental health or physical health, they are recommended on the background of how long it's been used for. So if you kind of take a medication that is being in the system for maybe the past 50 years, 20 years, 10 years, and people have used it, but then people have used it, and invariably pregnant women have used it, but there isn't any research or any statistics to say, okay, these pregnant women use it and the outcome was this impact on the baby, or they had these malformations, then you can safely say as a doctor that, okay, this medication does not seem to have that implication or that impact, so we can safely use it. So what I'm trying to say is that no doctor can tell you hand on heart that any medication is 100% safe. What we can say is that based on all the research that is available, there isn't any research, or is very little research, to say that this medication causes this malformation in the baby, or this medication causes you to have an abortion, or for the baby to abort. So therefore, looking at your mental health issues, and that is where you hear most doctors talk about risks and benefits, or the balance of risks and benefits. So when you're looking at a woman who is severely depressed, who cannot eat because of the depression, who is not looking after herself because of the depression, who is making herself vulnerable, maybe going out at the odd hours of the night because of her depression, just totally sleeping all the time, not being able to do any exercises because of her depression. And looking at that and the implications of that, and how that would pan out if you don't do anything about it. And then looking at a medication, antidepressant, and at present, I think most antidepressants, and any doctor recommending any antidepressant would know which ones are felt to be safe. Most antidepressants are felt to, that the percentage of causing an abortion, or the degree at which it might cause a malformation, is very low. if you look at the risks and benefits of it, then most doctors looking at the woman's presentation, the implications on the other children, if they are available in or the other children at home, the impact on the whole family, most likely under those circumstances would then recommend or would say, would just in discussion with you, with your spouses, with your family, say the benefits of being on medication actually outweighs any risks that it might have on the pregnancy, and therefore they would then recommend pregnancy. But ultimately, depending on what your capabilities or kind of how, what we call your capacity, they might decide you have that the opportunity of deciding whether to go on medication or not. We tend to try and catch it early in terms of the depression, and therefore, if it's mild to moderate, then the national guidelines recommends talking therapy, and therefore talking therapy might be what's recommended. Putting the issue of medication to perspective again, when you think about it, research shows that 10 to 20% of most pregnancies do abort naturally without doing, if you take 100 women, 10 to 20%, if you take a percentage of women, 10 to 20% would abort the baby naturally without anything happening, without being on any medication. The pregnancy could abort. 1 in 40 pregnancies, unfortunately, babies might come out with malformations without any medication, or just by virtue of nature, such things do happen. And therefore, that's where the doctor would kind of have the discussion with you that even without being on medication at all, you might abort anyway. So why not try medication? So those are the discussions. It can be difficult discussions, but those are the discussions that your doctor, your GP, hopefully your psychiatrist would have with you. And it comes down to, once again, the risks and benefits of it. What is the percentage of you having an abortion with this medication, and what's the percentage, if you put it realistically, the percentage of you aborting without even medication anyway? So why not take medication, which most likely will make you better, give you some level of function for you to look after the pregnancy well, eat well, do exercises well, look after your family well. And that is where the risks and benefits really kind of comes from. And that's what the preconception counseling try to discuss with you, or subsequently, if you kind of, with women who have not had many mental health issues before and you're diagnosed with a particular mental health issues, those are generally kind of the discussions that come up. Ultimately, it's down to it's the woman's decision. I cannot make it clear that enough. It is your decision as a woman to make that, because as I said, no doctor can put hand on heart and say 100% that this medication is 100% free of any implications. So ultimately, we can just share the information with you and discuss it with you. And if you do have capacity, then you ultimately see your decision. Sometimes when you come to puerperal psychosis, where the woman has no idea of what's happening, and they deem to be a risk to themselves and to others, then professionals are obliged to intervene with medications, whether one agrees or not. But outside of that, it's ultimately kind of down to you, your spouse, to you in discussion with your spouse and your family, really.
Great.
So,
I think
yes.
there are a couple of questions,
Yes.
so maybe whilst you're on medication, someone is asked if you could clarify the issue around medication. Are you saying, for example, that paracetamol isn't safe during pregnancy?
So what I'm trying to say is that all medications, because of the way medications are tested, you can't test medications on pregnant women. And so any most medications, they implicate the any statement about how safe they are is just based on historic facts that nobody kind of, if you take 100 women, maybe only one had this outcome or had this impact on the fetus or the baby when they took, let's say, paracetamol. And therefore, we can safely say that looking at those huge percentages, that paracetamol is safe to take. So that's what I mean. It's kind of, we don't have any statistics to say 100 women were tested on this particular medication. And the research would only, it's all retrospective research. So 100 women for over the years have taken, 1,000 women have taken this medication, and only one or none of them came out with something. So therefore, we can say on balance, it's reasonably safe to say. So that's what I mean by medication. So all medications kind of have, it's just a balance of it. Some medications are fairly new and they are very good with, if you take individuals who are not pregnant or individuals or men, it's very, very good medication. But because of maybe they just came 2 years ago or just last year, because we don't have that natural statistics of it, and no women by virtue of research can be tested, no pregnant women can be tested on it, then such a medication would not be deemed to be safe until maybe years down the line, where sometimes without really knowing the implications of a particular new medication, once again, the risks and benefits of it might say, okay, looking at the balancing it out, it might be safer, the risks, taking that risk. And therefore, over the years, then you have such a medication then being clear to be taken by pregnant women. So that's what I'm trying to explain.
Thanks, Dr. Sarfo. I think, Diana is on, Dr. Asante.
Oh, okay.
As well. So over to you, Diana.
There's a hands up from a Dominique. I don't know if Dominique wants to ask a particular question.
Yeah, we'll bring in Diana, and then we go to, yeah.
Hello, good morning, everyone. Thank you, Dr. Sarfo, for a wonderful presentation. I've really enjoyed it. I didn't join early, but I joined in the middle, and I've really enjoyed it. Just something brief to add regarding medications in pregnancy. Absolutely what Dr. Sarfo is saying is the case. So for a medication to be deemed safe, it needs to have gone through rigorous testing. I'm not just coming up with a medication in the lab, not just doing sort of equations to see that, oh yes, this medication works. But actually part of the trials of it involves testing it on the people or the species that you intend to use it on. So typically, in an ideal situation, it should be tested on human beings where people have taken it, they've observed them, and they've made sure that there are no side effects or there are no ill effects or teratogenic effects, as we call it, which is abnormalities on the babies. Clearly, we can all understand the ethical implications of subjecting a pregnant woman to a medication which we don't know what the outcome is. So most of the medications that are used would have been done on animal studies. And so even if the information on teratogenicity, which is the abnormalities in babies or the fetus, it would have been noted in animals. The side effects, the things that we talk about, the things that are listed in our books would be based on animal studies, because as Dr. Sarfo said, you cannot ethically subject any pregnant woman to a medication that you are trying when you don't know what the outcome will be. So based on animal studies and based on the retrospective studies that she's mentioned, that over a period of time, they will look back and say, of all the women who have been taking paracetamol, how many people have had an adverse effect? Information is put together. So that is why we cannot hand on heart 100% say that any medication is safe in pregnancy. And we can only go by the risk-benefit analysis to say that if we take this medication, these are the risks. If we take this medication, these are the benefits. And balancing the two is tilting towards this side. So I just wanted to chip in that it is a general thing that in pregnancy, there is no medication that we can hand on heart say is safe. But of course, we've had lots of studies. We've had lots of other sort of comparisons, as close as can be, but there isn't one that you definitely would have had done in real pregnant women to be able to validate that information. Thank you.
Thanks, Dr. Asante. I think, Dr. Sarfo, earlier on when you were talking about, prevalence of mental health issues, someone asks, what's the prevalence in women that have had children before? So those who are not first-time mothers, are they more resilient, or are they less likely to have mental health issues compared to first-time mothers?
Okay, so thank you for the question. So the mention of the first-time mothers was really in reference in the context of the postnatal blues that is more common in first-time mothers because of, by virtue of lack of experience, if you can say that, then because there's a lot, then there is that loss of apprehension about it. But generally, looking at mental health issues, mental illnesses overall, first-time mothers are not necessarily increased in terms of it being more common in first-time mothers than the other mothers who've had other children. When you haven't said that, when you take somebody who has maybe, when you take puerperal psychosis, as I mentioned in particular, I guess if a mother has, if you have somebody who had two people who've had previous diagnosis of bipolar affective disorder before, and one has had a baby before without having a puerperal psychosis, then you wouldn't necessarily be that worried in the second pregnancy, but then you'd be more worried for the first time mom, because you wouldn't know if that's going to happen or not. So in that sense, maybe first time mothers not necessarily at increased rates outside of the baby blues, but you'd be more, a GP or a psychiatrist will be maybe paying attention to the first time mom who we have no evidence to support to say whether she's going to have a relapse during the pregnancy or after birth or not, than somebody who has had a first baby already, who's had a first child already, this is their second pregnancy. You wouldn't be that anxious about the second pregnancy that you would be about. Yeah, I hope that clarifies it a bit.
Yeah, thank you for that. I think I personally am learning quite a lot, today, and considering I'm a church leader and we're always praying that people will get pregnant, this side of stuff, it sounds massive, and so thanks for talking about that. I'm going to bring in Dominique, but there's one question and then we'll go to Dominique. If a woman develops depression during her pregnancy, does this impact on the fetus? And is a child more likely to develop mental illness, when they grow?
Thank you for that question. So there is some statistics to show that, once again, in retrospective researches that have been done, that people whose mothers did suffer with depression maybe are more prone to a very small degree to having it themselves, or the tendency of having mental health issues is increased by slightly compared to the general population, but it's not a massive kind of difference. And also one has to bear in mind that aside the medication itself, I think the pregnancy itself, or suffering depression in the pregnancy, that what we call nature and nurture, being born into an environment where the mother is depressed actually has more implications on the individual, more than the actual suffering the depression during the actual pregnancy. So it's more of I think the postnatal impact is more significant than the impacts of the depression during the pregnancy. Hopefully that answers. I hope that's clear enough.
Yeah, thanks, Doc. I'm going to bring in Dominique and a couple more questions for you. But this morning we're delighted to have two other GPs joining us, and
okay.
She was on earlier on. She's a neonate. So Dominique, over to your question.
Thank you, Charles. Dr. Sarfo, thank you so much for having us, and it's quite a pleasure to have someone like you here. I have two questions. First of all, I think one is for a woman who is a pregnant lady, especially in our community, it's very difficult for us to talk about mental issues while we're pregnant or even after pregnancy. And especially for the baby blues, I think, especially for African women, it's very difficult to open up about it, to even talk about it. I think it's always ignored. Our culture doesn't even encourage talking about this kind of issue because it's kind of a taboo. What will you advise? Because I've had 2 children and I'm sure I've gone through that. But what would you advise women in that situation? Because sometimes even the doctors, because we don't talk about those issues when we go to the GP, and sometimes they don't even recognize it easily because there's no physical sign to actually say you're mentally you have a mental issue. So how do we get to the stage whereby we are able to actually open up about it? And the second question I want to ask as well is in general is also, how would you advise the general public, especially Black women in this situation, not just for being having the baby's blues, because we know we're going through difficulties in life, but how do we get to the point where we're able to go to our GP to say we're having this, we're struggling with our thoughts, we're struggling with certain things, and not making it a stigma, especially if you've got family members who cannot even dare talk about it. How do you get to a point where you leave from not saying a word and opening about it to the public?
Thank you for the question. It's a very good question, a very good observation. And that is unfortunately truly the case in terms of, especially in terms of mental illnesses within our Black communities. The taboo is still very prevalent and it's kind of still very there. But I guess it's difficult. And I think that this is a venue for acknowledging the stigma and as a society opening up to people, because yes, the individual, I think the individual who is suffering the baby blues definitely do kind of acknowledge it and would notice it. And as kind of you're rightly pointing out, is the challenge is now making family aware of it. And I think it's just making our own. I think sometimes, I guess, the challenge with people have come across is that by acknowledging it, you make it worse or you make it real. And I don't know, it's quite an interesting discussion that people feel like when you acknowledge the illness and it's real, if you don't acknowledge it, then it's not there. It's an interesting one. But I think my view or my understanding is that most health visitors, and I think most women, all women within this country, at least within the first 6 weeks or the first week, would have a health visitor come in. And I think if you as a woman find it difficult discussing it with your family, the most health visitors I think most health visitors are actually encouraged to use some screening tools. And I think if you find it difficult talking to your family, then you're recognizing that the health visitor is there, wherever the color the health visitor is there in terms of their professional capacity, and they are obliged to listen to you. The tricky bit about baby blues is that it is quite common, and therefore what I want to kind of disperse is that don't feel that people not to feel that they are being dismissed if you are not referred to secondary services or other services, maybe psychological services, because it's a common thing. Most of the time it's felt that after the first 2 weeks it settles down. So that is where you kind of maybe read about it, do some online CBT about it, just thinking it through. And I think that it comes from most people's inexperience and their anxiety. So most midwives would not necessarily refer you on to anywhere. It's more of reassurance, challenging your thoughts. And actually, when you're referred to the psychological services, what they tend to do, or the basic, I'm not kind of saying that is all they do, but the basic gist of what they do is to help you challenge the thoughts, the negative thoughts that come up, and then putting them in context. If you're thinking, oh, you're not a competent mom, what is it that you're thinking that makes you think you're not a competent? So challenging those thoughts, that's most the basics of what talking therapists would do. In terms of the bigger stigma, I think as a society, as Charles is doing now and as other avenues are doing, is to just really try and talk about it. Because I think that is the issue that, but then with all mental illnesses, I think one in 4 of us do suffer with mental illnesses at a point in time. So anybody who would say that you haven't come across a relative or a very close friend who's had a mental illnesses before would be blatantly lying. And that is where we have to start talking about it. It exists. Not talking about it doesn't mean it does not. It's not there. We just have to start talking about it. I'm not sure if that answers your questions.
Yes, it does, Dr. Sarfo. Thank you.
Thank you.
Thanks, Doc. There's someone is asking, if you can explain PTSD.
Okay.
Sorry, could I just add quickly to
Yes.
the baby blues one before?
Of course, yeah.
Yeah, just very briefly, just for in addition to what Dr. Maame Sarfo said, from a practical point of view, I think most of the time, like if you look at this forum, for instance, most of the people here are women, and we need the men to hear these things and know about these things as well. So because they're the ones who are supporting us through the pregnancy and when we're having the children. I mean, I know that most of the time when people have a first baby, we put in all the effort and everything, but further down the line, we are like, oh, actually, we know what we are doing. And it might be surprising because I was having a chat with Maame a few years ago, and I think it was our 2nd or 3rd pregnancies. And we were saying how really tiring it had been because it was a different dynamic. You have kids, you've got a job, and all of that. And even though the first time, everyone is expecting it to be really difficult first time because that's your first pregnancy. Like she said, it's not necessarily first pregnancies. It might be your 2nd, it might be your 3rd, it might be your 4th, because life is a lot more complicated then. So the antenatal classes, the antenatal resources, and whatever is available antenatally, I would encourage people to go, and please drag the men along, take them along. They need to hear these things because it's only when they hear these things and they know, they can understand. If they see that you've had the baby, you are sitting there quietly, you are not eating, you are down, they can understand what would be going on. I have a friend who has had a baby and she's going through a tough time. And she said, I can barely get myself out of bed to go and eat. And my husband is expecting me to still be cooking him 3 square meals a day. He gets cross because I'm not cooking, because I'm not cleaning, because I'm not doing all these things. And she's down and she's depressed and she's crying. And yet she's unable to speak to the man about it. So we need to incorporate and engage our husbands and respectfully and politely ask them to also come along to these things so that they'll also be aware. And we also need to talk amongst ourselves for support, because one thing I know definitely is that having a baby is a very trying time. And no matter how skilled and experienced you are, there was one day I was at home with my baby alone and the health visitor came to check on us. And just that little interaction for about 30 minutes or 1 hour that she was there speaking to another adult, because for the past 6 weeks, all I'd been is basically changing nappies, changing poos, feeding, crying baby, that sort of thing. My husband goes to work and comes back because he had to go. And just having someone adult to talk to have an adult conversation, something different from hearing a crying baby, something different from just looking through the window and thinking, when am I going to change the next nappy? When am I going to even have a chance to go and do a wee? It really made a difference. So let us help and support each other. As Black communities, we are really good supporting each other. When people have a baby, we rally around them. I know COVID is restricting us, but even if it's a phone call, even if it's a video call, anything you can do to check on each other. And let's speak to our GPs and our primary care services. There is help available. Thank you.
Thanks for that, Dr. Asante. Over to you, Dr. Sarfo.
Yes, thank you for that, and thank you for the contribution. That's really helpful. Just to add about the medication issue. I'm sorry if I'm going on a bit about it, but it's always an issue that comes up. We just have to bear in mind, having said that, the medications are all medication can't 100% say whether they are teratogenic. Risks of malformation is there or not. There is major with all pregnancies and with all medications, be it physical health or mental health medications, the biggest impact is felt to be in what we call the first trimester, which is actually the first 3 months. So most of the time in discussion with your GP, your psychiatrist, or whoever the doctor is, most of the time the discussions then comes within the first, depending on which medication it is, and depending on how unwell you have been before you were on medication, there might be a discussion of just saying, in agreement with you, saying that maybe the first 3 months, we might try and risk you coming off medication because of the impacts, because you have a larger impact. Most medications, if they are going to cause malformations, it's usually in the first 3 months. So therefore, discussion with, and I can't emphasize that enough, that in a discussion with a professional, you might decide then to come off medication during that first 3 months. It's important you have that discussion with a professional, because some medications you can just stop one day. You've been taking it and you can stop today, and then that's fine. There are some medications that you need time. It has to be gradually reduced before you stop it. A medication like lithium is used to treat bipolar affective disorder, and most of the time some forms of severe depression. It's one medication that if you stop abruptly, you can be confident that in the next week or in the next few days, you are definitely going to relapse. But there are also, unfortunately, some antidepressants that you stop it, then you're having withdrawal effects. So with all medications, even if you're wanting to stop, you want to discuss it with a professional first. You might want to consider stopping in discussion with a professional once again in the first trimester, where you have most malformations. But it's felt that as the pregnancy, the second trimester, the third trimester, the risks of malformations, and most of the time the impact, when we're talking about malformations, more of the time the impact on the heart or the impact on the spine, when we talk about the neural tube defects, those happen in the first trimester. So in discussion with a professional, you might want to consider maybe coming off the first 3 months, once again, considering, bearing in mind how unwell you have been or how unwell you are now, and if there are the risks and benefits of coming off medication now for it to be reinstated. So those things happen. Kind of, we have that discussion with professionals, and you might decide, okay, first semester is good to come off it and then come back on it. So I just kind of wanted to mention that. Just to add what we were saying earlier in terms of social management, which is basically a society and family supporting people. Sometimes you can see a neighbor, they might not necessarily come to you. And I think sometimes it's a tricky society we live in. And some of us not born here or not brought up here kind of find it a challenge. But if you know somebody, kind of a neighbor who's had children, who's had a baby recently or had other children, you can be proactive in maybe saying hi, or maybe sending a flower, a fruit, or something to establish a connection, just for them to know you're there. Sometimes that's all people need, to know that, okay, this neighbor was friendly to me. That sometimes that is enough for somebody to approach you. And as a society, if you want to do more, want to do something or destigmatize this, you just have to make yourself available. It's like maybe in church, you can approach somebody and just say a few words to her, and just genuinely, if you're available, make them know that you're available to talk to. Sometimes that is just enough for somebody to approach you. So that is kind of, we are all, most Black communities here have big church societies. And this is the avenues to make ourselves useful, and the church destigmatizing mental illness. Mental illness is not caused by the devil, as far as I know. I mean, I'm sure people have other perspectives about it, but at the end of the day, I say about any mental illness, whatever is causing it, And I'm sure I've given that example here before where a consultant was confident, yes, we can detect these brain changes and we know what's causing it. And there here was a priest or a father saying it was caused by the evil spirits. But at the end of the day, okay, the point is we are all agreeing there is something wrong with this lady. And I can never see how medication would interfere with praying for somebody. And we can all marry the two, whichever background we come from, whichever society we come from. One thing that I think I want to mention, and I realized during the course of my training and my working life now, I've experienced that comes up in the context of perinatal services, psychiatry, is social services. It's kind of, in a way, it's kind of a big taboo. When you mention social services and people, run for the hills, really. In my experience, yes, I've heard stories about people having bad experiences, but I know from my experience that social services really are there to help people, and people that I have referred to, what they've done to establish support there for them, maybe point you out to things that you can access. Some areas have Sure Start, some areas have Home Start. There are different things that are available that social services can provide. And my general understanding of social services, I'm sure people have had worse experiences, but my general understanding is that they're trying to help, and with their utmost aim with most social services, and we do have a lot of Black social services, is to try and keep the child within the family. So I think we just have to develop some trust there. And I find that over the years, people tend to, there are lots of services that health visitors tend to offer, but as Black communities, and myself being a very bad example, I didn't take up those opportunities when I had my babies. They have these groups that you go to, and sometimes just putting your baby down on a mat and having a good gossip or something different from your home environment is just enough. Yes, sorry, maybe somebody's raised up their hand.
Yeah, so I'm going to bring in Serge, but earlier on there was a question from Charles. Morning, doctor. Thank you so much for your presentation. It's very interesting. It must be very difficult to reach pregnant women who need help in our community if they haven't presented with previous symptoms. How much of some of these challenges are down to changes in hormones?
A very small degree is down to changes in hormones, but unfortunately, a very large degree is the stigma of our society, or our assumed stigma, that people then tend to wait till it's very too late. It gets very late. They tend to try to manage things on their own, or they don't talk to it. So to a degree, yes, I do agree. There are some hormonal aspects of it that might prevent people from seeking help. But I think it's largely the stigma of it, or the stigma of what people would say, or the stigma of somebody, a professional, there visiting my home, stops people from seeking help. And yes, if you're lucky with baby blues, it will just fizzle away. But with most serious mental illnesses, it does not fizzle away. And then unfortunately, what the first thing you're trying to avoid by avoiding people nosing into your, or people, the stigma of people knowing about your illnesses, like with puerperal psychosis, people tend to lose absolute control. So what you are trying to prevent at first by not seeking help at the initial stages, you find yourself reportedly being naked in the streets, or putting your baby somewhere. And I think that ends up then causing a bigger stigma, or a bigger stigma than you initially intended for it to cause. So yes, there's that stigma there, but you have to seek help. And I think what stops people from seeking help, unfortunately, within our Black community, is the stigma.
Okay, right. So I'm hoping we can have you back, because there are so many questions we can answer. But I'm going to bring in Serge as the last one, and then I'll follow up with another date so that we can explore some of these further, because I think there are some terminologies that a lot more people want to really understand. So over to you.
Yes, sorry. Yeah, kind of, sorry, I remember the question about the PTSD. Sorry, it stands for post-traumatic stress disorder. And it's largely, so people who somebody who has suffered with a post-traumatic stress disorder would have witnessed a traumatic incident where they had felt at a point in time that they were either going to die themselves or watch a loved one die. And that then leads to symptoms of numbness or symptoms of whenever you hear a car horn, if it was a car accident, when you hear a car horn, you panic, or whenever there is a situation very similar to what you witnessed, you kind of tend to have flashbacks, or you have what we call day nightmares. You'll be there and reliving so those are some of the symptoms, and that's what we call PTSD for short. It stands for post-traumatic stress disorder. There is good treatment out there for it. Thank you. Sorry, I just remembered that question.
That's okay. So,
yes, good afternoon, everybody. Good afternoon to the panels. Thank you, Charles. Thank you, Dr. Sarfo. And yeah, it's an interesting topic. Yeah, I only have like one observation actually. In comparison with the society and the community from where we're coming from. For example, I'm from Africa, especially precisely in Cameroon, born and raised there. And from my own observation, I've noticed that our mothers and sisters show or express a little sign of mental illness or depression after giving birth or during their pregnancy. I'm thinking that could be due to the fact that you have that social network around you to help and support, support you through this time. And in this community where we live today, we have less of that. And sometimes we find our sisters giving birth, and being home alone, and they don't have the network there to support them. Sometimes we can't afford to bring people from home to sort of come and give you that warm network that we have at home. So my contribution could be like, maybe we could, add it to other solution that's already available, and maybe have like some kind of network, like women or community network, to support our sisters and mothers in the UK or maybe in the Northwest or something in that sort, to help. Because you've found out that sometimes people open up more to to people from their background or from their from their community. Sometimes it could be difficult for somebody to go to a GP and start opening about something that even growing up we were not, this was probably taboo to us, because you have the network there at home to support you, and that sort of sometimes cure itself because you have the support around you. I don't know, maybe we could also have something like that in the UK to support each other. There could be something similar in the Asian community. I can't, I'm not sure, they have some women's society programs sometimes, and they have meetings to support themselves. Maybe this is something that we could be thinking about. Yeah, that was on my contribution, Dr. Sarfo.
Thank you for that contribution, Sage. I just kind of, yes, you are very right. You are very right in terms of, I also come from Ghana and I was brought up in Ghana, so I do really understand what you mean by that. And as back home, as a society, there's a larger society, there's a larger community that tend to support you. And yes, as I've said, alluded to, that support is very helpful with mild cases. Postnatal blues is very helpful with it. Moderate depression is very helpful with it. In as much as our societies back home, our communities back home are supportive, I just have to point out to the fact that it also has, like any society, has its negative impact as well. Because if we are being honest, we realize that in as much as the community is there to support people, you then also tend to have, I mean, all my psychiatry practice, admittedly, has been in this country, but I do have people. I did my medical training back home in Ghana, and I do have colleagues back home in Ghana. In as much as the society is there, it helps with mild to moderate conditions. That is more what you need is a psychological aspect, the social aspect of it in managing it is there. But then, unfortunately, you tend to have the serious mental illnesses that families then tend to contain because of the stigma. And then you tend to have people then present, or women present, who are very unwell because of the same society thing that we have that is trying to protect us, or protects us. Indeed, I mean, it's not denying any fact, protects us, also tend to contain serious mental illnesses for protracted period of time before seeking help, or if they do seek help, indeed, at the end, because we have, I'm sure, well, I would like to think most people have experience of heard stories back home of women being changed to trees and things like that. We have women back home being told, well, said to be witches because of some proclamations, statements they are making. So we have all these things there. So yes, our societies back home are great, but it has this cons as well. I think, yes, as you're rightly saying, we could emulate some of those protective factors in terms of being a society and supporting people. We should try and create them here. But I guess with all the best will in the world, the community that we are living in is very multicultural. Personally, where I live, you see a Black person pass by and you stretch your neck to see it. It's very few Black people. And so in as much as, yes, if you live in a large Black community or live in a large minority community, that is great. But I think just relying on those communities to be created, it poses a difficulty. I can't emphasize enough. I do appreciate there are some reluctance to it, but there are services available. There are services, they try to create it. I think it's for us to tap in. Midwives, there are a lot of services that midwives have. There are groups that they have. And I think by virtue of, yes, it would be great if I had, when I was pregnant with my children, or when I had somebody with a Ghanaian background to speak to, who would understand me straight away. But here we are in a society that is not readily available. And I think we have to make use of what is available. And I'm sure I'm aware that most health visits in most areas, at least I can be confident about the area I live in, do have avenues available for such support. And I think that, as we are rightly saying, this is a community, it looks like it's a community out there that we can put something together. But what I don't want us to do is just rely on our own selves. Other people, not our race, not Black community, Asian, other minority communities, white communities, have most people's well-being at heart. And I think we just have to take opportunity of what is available. You can't wait for somebody to come from home to, sorry, yes.
Yeah, thanks for that, Doc. We're about to wrap up. I know Princess has a question, but I'll read this as well. Doctor, thanks for your presentation. What advice would you give to a doctor who wants to practice as a psychiatrist? As you know, per job seeking and mentoring, my younger sister wants to practice as a psychiatrist. But I'll bring in, Princess, and then you can, respond to those two as, the final. So Princess, can you ask your question?
Right, thank you very, very much, Dr. Sarfo. That was really, really wonderful. I wish these are the sort of things you should come and preach in our hospital, please. We really, really need to hear this. I mean, we've got so many BAME, Black, Asian people that are needing to listen, to be educated by this. A lot of people are suffering inside because of this. I've got a question. The question I wanted to ask here is the severely depressed people. Does it just affect just pregnant women? is my question. And if he does, is there any education on how to find out, like, say, how can it be defined? How can it be identified? How can it be identified at an early age? You know, the early stages. Is there a way to identify it?
Thank you. If I heard you correctly, you asked about severe depression.
Yes, darling.
Okay. Yeah. So the severe depression can happen in anybody, any man, any woman, any age, outside of pregnancy. It can't happen in pregnancy, outside of pregnancy. The emphasis on people when it is in pregnancy is because of the implications that it has on not just the woman, but you can imagine the baby as well. Because when you talk about severe depression, you're talking about somebody who is just sitting down, not doing anything, not because they don't want to do anything, but they just can't gather any courage, any oomph. The motivation is not there. They can't remember the last time they enjoyed seeing anything. If the woman has just had the baby, you can see them staring at their baby, not having any emotional bond or anything at all. If they can hear their baby crying, but unable to get up and pick the baby. So those kind of are the symptoms of severe depression. With some individuals, it then goes on to having psychotic symptoms where some people might just imagine, cannot hear the baby crying, but do not know what it is that is crying, do not even recognize their own baby, or might they have thoughts of their worthlessness, the baby is better off without them, and what are they doing hanging around the baby? So in terms of severe depression, their suicidal thoughts might be very, very high. They cannot, and I have to emphasize, it's not the person's doing, so it's not a matter of get out of it or get a grip. They cannot get a grip. It's just they cannot. And so it's kind of, they cannot just see, all they can see is the future not being very bleak. And within that space of time, they cannot see anything outside that. And because of the implications on the baby, sometimes we have people, what we call infanticide, people killing their own babies, drowning their babies, setting fires to their babies, or people indeed killing their own selves. We have examples of doctors, midwives, all range of lifestyles. So it's not to a particular class or group of people suffering with serious mental illness. I know somebody who set themselves on fire because they felt they were too guilty and they shouldn't have had a baby. They set themselves on fire. Somebody jumped over a bridge. Somebody kind of hanged themselves. Somebody drowned their baby and drowned themselves. That is where it makes it then more pertinent, or there's more attention given to in somebody with severe depression. So the symptoms are anything after, as I said, postnatal blues is just having doubts about your competency and things like that. But after 2 weeks of somebody just persistently being in a low state, persistently not enjoying anything, persistently being pessimistic about life, feeling, some people it's just a matter of feeling guilty, expressing guilt. Oh, I don't have to be here. You don't have to do this for me. I don't deserve it. I'm a bad person. And does not fit any context. You know, they are not a bad person, but they can't see it. So those are the symptoms that when somebody is coming up with it. But as I've said in previous times, it's not a good thing to make diagnosis yourself. It's just that if you are indeed worried about individual, point them out to a GP, point them out to a midwife, or when the health visitor shows up, you express your concerns for a professional to take it up, because part of this not creating that stigma is people not making their own conclusions about people's presentation, because then you have people, oh, she's just mad, and then it creates the stigma. So yes, if you're concerned about somebody, just find the right route to identify them, not necessarily making the diagnosis yourself. Thank you.
Okay, and Doc, finally, we're really grateful for your time. But the question about the young doctor who wants to become a psychiatrist.
Okay, yes. So the person who asks a question, are we talking about a British trained doctor or somebody who is an immigrant like myself.
Thank you, doctor. Is someone who is an immigrant. She just passed UK, this medical doctor kind of exam, but she wants to practice as a doctor. Yeah. Thank you.
Okay, so yes, so yeah, so she's passed her PLAB, so that is fine. I think with she would need to apply for the foundation year doctor. So depending on when we complete medical school, I know back home in Ghana, we used to do what we call house offices. I think it's all changed now. I know here they call it foundation year doctors, and we call what we have deaneries. So if she passed her PLAB, if she didn't do the foundation year back home, where she your candidate or her country of origin, she would need to apply for foundation year here, and then she would be 2 years of completing foundation year, and then she can then apply for psychiatry. So we have what we call deanery. So it's like a school, but you'll be working as a doctor, but in a way you belong to a school. So she would then have to apply for psychiatry within the schools. And if you look up deaneries, they have a lot of deaneries. And the PLAB, if she's completed her PLAB, I'm sure they'll provide her with that information. If she has done her foundation years back home already, then she can apply straight to the psych, go to the deaneries and apply straight to the deaneries, the psychiatric schools around. But I think if she goes to the GMC website, I know that they are now trying to recruit a lot of international graduates, medical graduates, especially into GP and psychiatry. So that it might be an easier way of an avenue of entering it. So if she goes to the GMC website, I think she would have more information there. Dr. Asante, I don't know if you want to add more about it in terms of GP land. If you're still around.
I just wanted to check if it's okay to pass your contact details so that you can provide some support offline.
Yes.
Is that okay? Yeah. Okay, yeah. Fantastic. So Tammy, I'll be in touch and I'll pass, Dr. Sarfo's number. So any final words from yourself?
Thank you very much. You're welcome. Yeah. Thank you.
So Dr. Sarfo, we're really grateful, but there are so many questions that haven't been answered yet. So I'm going to contact you and get another date, for November, if that's okay. But we're really, really grateful for, your time, and, can you give us your final words?
Yes, so just finally, I hope people found it useful. And as I said, 1 in 4 of us do suffer with mental illnesses out there. So nobody is immune to it. And so anybody who says or try to minimize mental illnesses is blatantly lying. In women, it's quite important, virtually by virtue of the fact that we are dealing with 2 people and not 1 person. Just being out there, identifying. You don't have to be a doctor. You don't have to be within any professional capacity, but identifying if your neighbor is struggling, your sibling is struggling, and talking about it, making yourself available for people to contact you, or maybe pointing them out so you can see they are struggling. They want to speak to their GP. And I think that potentially, if they are not prepared to speak to you, sometimes you might have to point out the obvious. Do you want to mention to your well visitor? Do you want to mention your concerns to your GP? Just pointing out the obvious to such people might be the kind of avenue out there. There are lots of mental illnesses that kind of are out there. Some of them are mild to moderate, where you just need psychological intervention. You just need a family supporting you. You just need the society supporting you. And there are indeed serious mental illnesses like bipolar affective disorder, schizophrenia, puerperal psychosis. I can't emphasize that enough. Be it rare, when it does happen, it's quite have significant implications that we need kind of just to be aware of and support society. Medication is a good thing to have when it's necessary, and any doctor worth their weight will discuss with you what the pros and cons are, the risks and benefits are of being on medication or not being on medication. And I think sometimes, yes, that you hear horrible stories about people's experience, but I would always say, until you've experienced it yourself, You have to risk it and go out there, seek the help. It is out there. Do not limit it. The help is out there. You only have to reach out. Thank you.
Thanks very much, Dr. Sarfo. Dr. Asante, anything you want to add?
Sorry, I've got a screaming baby in the background. Thank you very much, Dr. Sarfo. We've learned a lot. We've really enjoyed it. And I've also enjoyed the discussion. As she said, there is help out there. Let us be supportive to each other. Let us signpost people. And let us reduce the stigma as much as we can. Because it is a real situation. And currently with the COVID situation as well, the mental health issues have really gone up. And on a daily basis, we are seeing a lot of people who previously didn't have any mental health issues are beginning to present. So we all need to be there to support each other and access whatever help is available. Thank you.
Okay, thanks to you both. We're really grateful. So Dr. Sarfo, I'll be in touch for another date. And, on Tuesday, we have a consultation on mental well-being services in Greater Manchester. We're just looking for 12 people. Each participant will get a £25 voucher. So please come along, or drop us an email, to Sandy@CAHN if you want to be part of that. And then next Saturday, we will let you know, but we'll be back on between 11 and 12. So thanks everyone for, your time. If there are any other subjects or any other topics you want us to consider, then by all means, you know where we are, drop us a line. If you want to be part of our mailing list or you want to volunteer, please, let us know and drop us a line. And Princess, congratulations. You've been one of our volunteers and you now one of the governors at MFT. So welcome on board. So thanks everyone. Have a wonderful weekend and we will see you on Tuesday for our physical activity and nutrition session from 6:30. And also let's keep looking after one another. I think the Prime Minister has a press conference later on, at 4 p.m. if it's another lockdown. As we encourage, check on others, whether by video or telephone call. Bye, everyone.
Thanks,
Thank
Charles.
you.
Bye.
Thank you. Bye.
Happy birthday, Pastor Charles.
Oh,
Thanks, Teresa.
happy birthday, Pastor Charles. I didn't know that.
Thanks, Princess. Thanks, everyone.
I'm coming for my cake when it's time.
All right.
Bye.
Happy birthday.
Thank you.
More life, more strength to carry on.
Margaret. Thank you.
Thank you.